I was curious before we dive into all the meniscal stuff, because Mike, you're the first sports and exercise doctor I've had. I've had a few
Okay.
others from A&E and neurosurgery and other bits. But I was very curious when I was thinking about this episode, how does, as a SEM doctor, especially with a football team, how does the work-life balance with that compare to being NHS doctor, if we call it that?
Yeah, it's a good question. I think both of them pose challenges in different ways. So my background and base specialty is also emergency medicine. So I have
Um,
a job share in sports medicine at the moment. So 50-50 with one of my colleagues, and the rest of my time is spent in A&E. So juggling the two certainly can be challenging in terms of a work-life balance, but I'm a lot happier now with the balance that I have than what I probably had 2-3 years ago. So it's just continually trying to find what works and keeps you motivated to keep moving forwards.
is it I've never done with the natural club. My brief sport experience with this martial arts years ago, doing that, but that was with like a gym and very much just an evening kind of thing. When people talk about sport, they talk about it being the never-ending job. Like you're always, is it what people think it is in their head when you're part of a club?
Yeah, definitely. I think you feel like you're on call 24/7. As I said, I'm quite fortunate that my team that I work with are very good. I have a job share, so we're quite good at clocking on, clocking off, and
Yeah.
making sure the comms between us are good and pretty slick. But yeah, we'll always still get messages in time off. That's just sport.
Yeah. Why sports and exercise medicine have interest? What made you pick
I've
that?
always had an interest in sports. So played a lot when I was younger. Mix, I'll have a go at anything, but predominantly rugby union. And then I did an integrated degree in sports science partway through my medical degree, and then it kind of just snowballed from there, really.
Grand. And Carl, why legs?
Um, it's a good question, and I have been asked this before, and it's always a tricky one to answer, really. I guess when I first, before I even became a physio, I did a diploma in sports therapy.
Mm.
It wasn't a degree, so I can't claim that, but it was kind of, it gave me that opportunity to work with sports people, and there was many of them who obviously had lower limb related injuries. My interest in sport from is generally around football, so I tended to see a lot of lower limb injuries, and kind of on the back of that, I'd always had that sort of seed planted. I think that lower limb was my interest area, and actually then did all the NHS rotations as a junior clinician, and then moved up through the ranks, specialised in MSK. But then I was always kind of fed more lower limb stuff, even though I wasn't officially a lower limb practitioner
Yeah.
until maybe 3-4 years ago when I kind of then specialised in lower limb. And because my interest there has always been with sort of ACL related injuries, I just find it fascinating. On the back of that, I then kind of became the ACL man in Leeds, and
Yeah.
and again everything kind of fed my way, and again you just get more and more specialised the more and more you see, and an opportunity came up for me to specialise in an acute knee clinic, and that's where I am now.
Where we are now. You mentioned ACL. We will come on to meniscal injuries, which we'll talk about more in a minute. With ACLs, why has this become such a popular a body part of all the like? I feel a bit sorry for the meniscus because everyone bangs on about knee ligaments all the time, and the meniscus probably I don't know the injury rates we've discussed, but people kind of go, oh yeah, there's that as well, and everyone focuses on that. There's you can find ACL specialists, well, you said physios, doctors, whatever, but no one seems to be claiming meniscal specialist anything. Why do you think that's just become the popular tissue compared to cartilage?
I think the reason behind it is there's just more money in terms of funding around the research side of things. It was kind of popularized in the 90s with football players like Paul Gascoigne and a few others who had these huge injuries, and at the level that they play at, I think there was just a lot of funding that's gone into trying to look at how can we prevent this injury. It's a devastating career-ending injury at that stage when it was first around, until the ACL reconstruction became apparent. And yeah, it's sports across the world, isn't it? Your netballs, your American footballs, basketball. It affects all pivoting-based sports, and I think these are the sports that seem to have the most of the finance, and I think that's probably what drives the majority of the interest in ACL.
Yeah.
Would you
Mike,
agree,
what's your
Mike?
thoughts?
Yeah, I think so. I think also the general public have that awareness because it just ends up in the media a lot. As you say, Carl, it's a big injury, not just in terms of structures, but time loss from a sport perspective. Even just your weekend warriors. So it has immediately in their head, it's a massive impact and affects what they're able to then do. And then on top of that, because the rehab is therefore over a prolonged period, people just have a bit more awareness, I think, of ACL as an issue with the knee.
Yeah, it has bigger press, doesn't it? So we'll stick on that subject for a minute because I normally save the plugging of the things to the end, but we'll mention this now because you have this lecture coming up. It's next month, is that right? With the guys coming over from Australia.
Yes, so we've got a talk coming up on the cross-bracing phenomenon, questioning whether an ACL injury can actually heal without surgical intervention. So we've been very fortunate to get Associate Professor Steph Philbay and Dr. Tom Cross flying across from Australia to deliver this talk at Leeds Beckett University in Headingley in Leeds. So we're really excited to hear from them, to be honest, because it's an area that isn't really that popularized in the UK, certainly in an NHS setting. Whereas there's a lot of noise coming out of Australia of how important it is to consider this as a third option when it comes to ACL injury, rather than just going straight down the line of ACL reconstruction or managing it as an ACL deficient knee. It's giving that additional option there of could bracing at 90 degrees, could that help to unify this ligament if we catch it in this acute phase? So yeah, we're really looking forward to hearing from them, and sure there'll be loads of questions and debate around it, and particularly with the surgeons. We've got a few surgeons who are coming already that we've seen. I'm sure they'll be asking questions, and we want to hear the answers to these questions as well.
People can sign up online, right?
Yep. So it's a hybrid, so they can sign in to join us online, and it's face to face as well. Okay. We've also got student tickets available.
Good. I can stick the link in the description for this. People can just click on that as if they're listening or watching and get it. And that's in Leeds. What was the date? Remind me.
It's the 4th of November, so it's Tuesday the 4th. It's 6:30 kickoff.
Fine. And you say brace. Is this I try not to spoil it too much, but it's the premise that are we talking external brace, like a knee brace itself, and not inside the knee, so to speak?
No, not inside the knee. It's an external brace that's fixed at 90 degrees. If we can catch it within the first few weeks of diagnosing an ACL injury, then with certain types of ACL tear, and this is where the nuance comes into this type of option. With certain types of tear, there's potential for it to heal, and there's been evidence shown, with repeat MRIs, that it's suggesting that there is continuity of the ligament after 12 weeks of being in a brace. So there's something in it.
Could this be an option, Mike, for the future for teams? Do you think? Because that sounds much more appealing than being off for a year.
Yeah, sure. Yeah, I think we're a fair way off knowing that at the moment. I think in the elite sport arena, if anywhere follows suit with the bracing protocol, I think that is some way off yet, just because of the inherent timescales that are put on elite sport and players that play at that level. There'll be lots of questions, I'm sure, and some good debates between our surgical colleagues around that. The evidence might suggest that there's some continuity of the fibers, as Carl said, and that it's healing, but that will be how functional that is at the end of the rehab period versus an ACL reconstruction. There'll be lots of questions to answer, I'm sure, down the line. But it's really exciting. But I think, yeah, from an elite level, that will probably come right at the end if it indeed ever creeps into that space. We'll see.
Wow. I'll tell you what, we'll leave a lot of that cliffhanger. People can go and join in if they want to. We're obviously going to talk about meniscal injuries tonight. And actually, it's handy, Mike, that you have this, the one side, the sport with the team, another side, the A&E with the public, I presume.
Yep.
If I was to, let's say you're in your A&E environment rather than with the team, we'll come to the team in a mo, but you're in A&E or Carl's in his acute knee injury clinic. And we've got, let's call her 28-year-old Steph, who's come in and you've, with a locked knee, very painful after a twist. You've done your assessment. There may or may not have been a scan and come to the reasoning that there's a acute meniscal tear there. And she says, "What's that?" Where would you start?
Yeah, I think it's a really good point. I feel quite fortunate, really, and I suppose privileged to be in the position. So, as you say, I get them at potential first possible diagnosis in the emergency department, but I also, before Carl moved to Leeds, I used to work in the same soft tissue MSK clinic there. So that's within an NHS environment still, but that would be at the next part of their patient journey, if you like, in our acute MSK service there. And then, as you said, that's very different than out in the private sector in with elite athletes in sport. So I think my approach certainly to that initial presentation in the emergency department is definitely different to what I would take if I was in clinic, just because it's right at the beginning of their journey. And I will have already taken quite a few cues from the patient in front of me as to how I would approach that. Lots of people, I think, particularly with meniscal injuries, drawings or models tend to be very helpful, just so they can visualize what you're talking about. There you go, Carl, very nicely.
Carl's got a knee that people might not be seeing. So you will get out the model and show?
Yeah, potentially. Definitely in clinic, but in A&E, they're not particularly to hand, so it tends to be my scrawls on a piece of paper or just showing them using their own knee or my knee, potentially.
Carl, what about you? Again, she's coming to clinic. This isn't an athlete at this point. She's just, let's say, works, I don't know, a desk job in the day and maybe does some weekend warrior stuff. But again, to ask the same question, you've got your model though this time, and you're not in a rush like Mike is in A&E, but maybe have a bit more time. Where would you go?
Yeah, so they would have landed with me following that initial assessment through A&E. That's how our acute knee clinic works. We kind of work alongside the orthopedic surgeons, so they would have had that first contact through A&E or possibly through GP and FCP. That's how we kind of get our patients through. So landed with me. She may have been given some prior information, like Michael just said there. But I always kind of like to kind of probe into that a little bit and try to get their understanding. So, as you said in this particular example, sounds like she doesn't have much of a clue as to what the hell she's dealing with. So I would kind of just delve in with the model, just explain to her what the structure is, that it's a fibrocartilaginous structure that's shaped as kind of two C-shaped rings within the knee. Contrary to what you would think with the blue colouring on this this model, it's not blue. It's a nice glossy white. And yeah, I would sort of explain that the ultimate role of that structure is to kind of absorb stresses across the knee and distribute that load through this circumferential hoop stress. So it kind of distributes it evenly across the whole knee. And the structure itself is kind of made of like an elasticated kind of substance. So the cartilage is quite elasticated with this kind of gag content that it has within it, as well as the fact that it's got 70% worth of water in it. Mm-hmm. And the structure is deformable. So as you're putting force through that through the meniscus, it kind of, as I say, distributes it across. So if you do have an injury to it, then as you can imagine, it's going to have an effect on the mechanism of the knee and the kinematics and how it can function normally. So if we've got somebody who's got a locked knee, then there's a few different tear types that can lead to that. It's that you could get a horizontal cleavage tear, and if it's big enough, that can flip into the joint and block the joint, causing it to lock. And you can also get a longitudinal vertical tear that does the same thing, really. Again, the larger the size, the more unstable it becomes, and the more chance of it flipping into the joint and causing it to lock. So it's then kind of deciphering, is this a true lock or is this more of a pseudo lock? I see many patients who come through the knee clinic who say that their knee locks, but then when they describe how it is, it's kind of that feeling of when the knee's stiff, and then they can gradually just ease into moving it. Whereas a true lock is, as you've described with this lady, that the knee's kind of fixed in a flexion-based position. It's struggling to be able to extend actively or passively, and there will be usually a tissue block to it. Sometimes you can manipulate it in clinic, and you can kind of rotate the tibia in respect of the femur, and sometimes you get kind of a release. But sometimes you just can't get any movement whatsoever, and in those cases we ultimately need to scan them and get a surgical opinion as soon as possible, really.
Do people ever come in thinking that locking is the right word to say, perhaps, to maybe escalate things? You're both nodding, so clearly I'm right. But is there a way, because people listening to this going, yes, whether it's the pseudo locking or the true locking, and they may be happy from the history, there's nothing obvious and may not have seen anything obvious, so significant meniscal tear, but someone will say it's still locked. From your experience, how have you found ways to, with the pseudo locking, kind of get it to come and unlock when it's not truly locked, if that makes sense?
In terms of describing that to the patient, you mean?
Yeah, or is there, when they're in front of you and they're saying, is there a way to help it when it is pseudo locking, to help it unlock, so to speak, when it's not really locked, if that makes sense?
Yeah, it's a difficult one, because they can be describing various ways of how this would happen. It could be, as I said before, it could be when they're in extension and they're struggling to bend it. It feels stiff, so they just gradually bend it. It could be that it feels like it's clicking and cracking, or they can feel noises as they're kind of loading it, maybe going into a squatting position. They can feel it kind of catching, and their kind of understanding or their perception of what's happening is that it's locking, the knee's locking. So it's trying to unpick what they actually mean by the terminology behind this knee is locking. And that can be quite tricky, and it can be quite nuanced. But if it's, if it is something that it's that it's, they're describing it in extension and they're trying to gradually bend it into more flexion, I would just kind of explain that that's kind of a normal thing that can happen, particularly if it's an arthritic knee, and if we've got evidence of that through the clinical assessment and through imaging and possibly through their background. Then I can just describe that, this is often what happens with an inflammatory process. When you're in more of a static position, the knee can feel like it locks up essentially, or kind of feels like it gets stuck, and then it just gradually works into it. I kind of use and rightly or wrongly, I don't know what you use for this, Mike, but I kind of describe when that happens in a stiff knee, almost like the kind of the inflammation kind of sticks to the soft tissues within the joint, and then to kind of release it, it's almost like a wet dog when it shakes the water off itself. You kind of shaking when you move, and you kind of gradually build into that range. You kind of try to shake that inflammation off the tissues, and then as you then are more mobile, it isn't a problem. But then as soon as you become more static again, you find that it seeps back into the tissues, and the same thing happens again. So it's then gives us you a bit more of a clue as to, well, this may be more of an inflammatory problem. do we need to look at how we manage it as an inflammatory problem? Is
Yeah.
it something more rheumatological that's going on in the background, or is it quite simply just a stiff knee from osteoarthritis? So yeah, it's very nuanced as to how they present and how they describe what this locking mechanism is.
Yeah.
It's very different if it's a true lock.
How do you manage that
Yeah.
in A&E, Mike? The locking conversation.
Yeah, I think in A&E we're always, sometimes I'd say we never even get that far in the consultation, just because often at the point of first presentation they're really, really sore, really, really swollen, and trying to actually get down to managing those special tests or try and isolate particular structures can just be really, really difficult. And that's why the things like the acute knee clinic Carl works in, the soft tissue clinics exist, and the referral pathways are important, that they get reassessed at a time when they can be examined properly. So sometimes I'd say in A&E we a lot of the time don't get to that stage of the conversation. You may get a good subjective off your patient where you're pretty confident that it's going to be some sort of meniscal pathology there, but getting into those more depth in conversations in A&E, I think, is much more atypical.
Can you unlock it in A&E or in the soft tissue clinic?
I think often I would always be a little bit cautious of that. As Carl said, it might happen during the examination just because of what you're looking to do, but I think there'd be particular things I'd worry. Our main concern with a locked knee, obviously, is that there's potentially a meniscal fragment that's preventing it from moving properly. And certainly at the stage that we see them, then as much as possible, we can protect that fragment. We give our colleagues in surgery the best chance of potentially repairing some of these injuries. So I think it would depend how they are in front of me. I wouldn't routinely try and manipulate the knee a lot, no. But we're obviously going to get them to move a little bit to try and ascertain what we can and can't assess.
Now, if we take, at the moment, Steph's a member of the public, not an athlete, but if we flip the script a bit and say she's 4 years younger, part of your team and a professional athlete, part of a squad, again, had the injury, had the scan, come to this diagnosis, does the explanation change at all?
I think the direction of the conversation, my experience of working with the elite athletes is very different. I think they immediately default to how much time loss is this going to result in, and what's the best way for me to get back, and not just get back, but get back to the level that I'm currently operating at and wanting to play at. So I think lots of the staffs that we saw initially in A&E and then would go through the NHS might understandably not want to hear that surgery is a possible option, whereas I think a lot of people in elite sport, that's their go-to. It's like, right, well, one of the first questions is, does this need an operation? So I think the conversations you have with elite athletes are move pace a lot faster to the kind of end points, but then you end up going back over lots of the other detail later on, if that makes sense. Whereas I think it's the other way around in the clinic. You sort of build up from, as Carl's just talking about the structures, what it's there for, what a normal one's like, and then what pathology they've got, and building up from there. Whereas I think often with elite athletes, it's completely flipped, because they go straight to the end and then you have to work slowly back from there, and then slowly they'll start to unpick it themselves and ask other questions.
With the shared decision making on that, is it, so you say they'll jump straight to that? Does it usually go any other way for at that age group? We're talking like early 20s, or is it usually a case of surgery to get back to sport? Is there really any other options for that group?
I think with the meniscus, it's a really interesting one, because they certainly don't all need surgery. I think in the elite sporting arena, though, certainly all the ones I'd say I've dealt with have done, just because the forces and mechanisms that are involved in the injury in the first place, they end up being significant tears. We're not looking at a degenerative in the background tear that we might be managing in a different setting. So I'm trying to think off the top of my head. You might get the odd one that's left alone, but that's because it's been associated with a different type of injury. They've injured some other structures at the same time. But isolated meniscal tears, if you've got to the point where you're scanning them and they're out of playing, it's usually because there's a decent tear there and they need to go and see one of my colleagues in orthopedics.
Now, Carl, let's say she's come again. We'll take Steph back to the public. She's not the athlete. She's come to you in your clinic. You've made the diagnosis. It's not locked, but I'm happy that the meniscal injury is there. How would you discuss her options with her about what to do?
Yep. So once we've screened, as you've just said, that it's not a locked knee, we can generally straighten it in clinic. That's really important. A lot of these knees come to us in slight flexion, not necessarily 90 degrees of flexion locked, which I've had a couple of times. And a lot of the time, that's where the knee likes to sit. So it's a matter of reassuring them that if I can passively take them into full extension, then in my mind, I'm already thinking it's less likely to be a bucket handle type tear or a loose fragment that's possibly just floating around in the joint that's possibly causing this locking. So it kind of screens that out. So in terms of the options that I can give them, then it ultimately depends. So you've got a young person who's had a traumatic injury. They're going to be managed very differently to, let's say, a degenerative 60-year-old who's had a low trauma rotational injury, let's say, to the knee, and they're presenting with meniscal type injuries which are not showing mechanical signs of locking. So they would be managed differently. So we tend to kind of split them into acute traumatic versus degenerative meniscal tears, as Mike sort of alluded to. So in this particular instance, you've got a traumatic tear or potential traumatic tear. We've got an MRI scan. Then it comes down to what the imaging tells us in terms of what is more likely to get better outcomes from a conservative approach versus a potential surgical approach. And if it was to be a surgical approach, the surgeons would always want to look at repairing the tissue first. Some tears have better propensity to heal than others, and there's a number of variables that play into that decision-making process. So just to give you an example, the meniscus, we tend to kind of look at it in thirds. So you've kind of got your more inner base third, which is classed as your white zone, which is avascular. It doesn't have any blood supply to it, but it gets some nutrition from kind of the synovial fluid within the knee. You've got your second third, which is kind of the red-white zone. So you've got a little bit of blood supply, but still not great. And then your periphery is your red zone. So there's more blood supply there, and that ultimately gives a better propensity for a repair to be successful. There's been a couple of articles which haven't necessarily put it into the kind of neat boxes of very specific injury types that have suggested that repairs can fail 1 in 5. So it's not so 20% failure rate is not great, but that's possibly the best option in some instances. But having that conversation with them, some people are just absolutely avid that they do not want to have surgery and they want to give physiotherapy a try, and that's absolutely fine. I'm more than happy to kind of support them in that process. And I know some people do better, and particularly if they're in that red zone, if the tear's in that sort of vicinity, there's possibility that the tissue will heal on its own without the need for surgical intervention. So again, it depends on the stability of the meniscal tear. If it's kind of seen and on the MRI that it's a more of a stable tear, it's maybe a small vertical tear, longitudinal vertical tear, then they can do quite well. They often do well. Whereas the larger ones, that are maybe a little bit more unstable, then that would be then having a conversation as to, okay, well, it's a larger tear. There's a possibility that this might not be as successful with physio or with rehab, conservative management even. So your options are surgical intervention, possible repair, or rehabilitation. And sometimes patients want to go down that rehabilitation route. And as I said before, I'm happy to support that. I think it's, as a physio, I'm very much pro rehab for this type of thing. But I'm also now been in this role for as long as I have been. I'm more appreciative of the role of surgery as well, that we can't manage everything with physio, and certain injury types just don't do well. Another example of one that possibly wouldn't do very well would be a large radial tear, particularly if it's near the posterior horn and affects the root. Then that particular type of tear will affect the integrity of the structure, and it won't be able to distribute those forces as evenly across the knee. And because of that, you're going to put increased load and contact pressure through a certain point on the knee that's going to increase the risk of arthritic change and degeneration, which ultimately at that age group is disastrous, to be honest. So they would want to go in and try to repair those situations, so then you don't get kind of tissue extrusion that pushes the meniscus out of the knee joint, and increases that risk of arthritis. So it very much depends. To answer your question, I will loop all the way back. It's to answer your question, it's very much dependent on what comes back from the imaging, I would say, in terms of how we would best manage those type of injuries. Would you agree, Mike?
Yeah, definitely. And as you've said, the patients will often surprise you, and they're involved, as you've mentioned, Ben, with that shared decision making. We had a case through. It's on our next NDT list to discuss. It was a young lad. This was in an NHS setting, who had a bucket handle tear to his meniscus, which is kind of, from our perspective, is one of the most likely ones to cause a locked knee, because the name obviously is alludes to the type of tear. So it's tear around the C shape of the meniscus. So it creates a handle like on a bucket that's free to flip in and out of the joint. So one of my colleagues spent a long time chatting to him, trying to explain the need for him to have quite urgent surgery to unflip that and try and repair it. But this young lad had been given what he just was describing at the time as a life-changing, I suppose, opportunity to go abroad with a job. So he was flying out the next day and he was having none of it. So he said he didn't want a surgery, he flew out. And I saw him in clinic a few weeks ago. So he's been out there just over 18 months now. Been very ginger with what he's been doing, but just tried to manage it himself. And pleased for him, obviously, the opportunity worked out. And believe it or not, his bucket handle tear is completely healed on his MRI scan. So you continue to get surprised every so often by things which you think 100% are going to be surgically managed, and he's obviously a very rare exception, but they do come along.
I guess if he's young, is it right if you're younger, does that help you with the healing? The more likely chance of it healing properly? Correct?
Yeah, I think definitely, as Carl said, it's a lot to do with that location as well. His bucket hand, I imagine, had a big proportion that would have had to be on that in that very vascular area, so he's had a good chance of healing.
Now, before we get to the degenerative kind, if we take the same scenario, an athlete in a team, but this time instead of being early 20s, they're mid to late 30s, kind of dwindling career, coming off the bench a lot more. How would you, and again, it's not locked, but there's a tear there. How would you manage that conversation about options for management? Does it change at all?
I think, again, as Carl said, a lot of the decision-making process is based on what the imaging shows, where the tear is, and importantly, how it's affecting them in playing. I think it's the stage of the career you've put them at. Some of them might just be saying, well, I just need to get through the next few months, get another year on my contract, and then I'm kind of done. So I don't want that time loss right now because it's just at the worst time. So that would definitely come into play for sure. And then again, if it was a big stage of a season and it's right close to the end, again, depending on how they were presenting and what was happening in the knee, they'd all be conversations that they'd be driving with us and with the surgeons as well. And that would very much have to be a classic MDT involvement. So they're quite clear. They're making an informed decision from everybody's perspective and the information from all of us, not just one of us as a practitioner.
And it sounds like, I didn't realize neither of you are orthopedic surgeons, but it sounds like they're trying to repair rather than remove the meniscus more. Is that right?
100%. Yeah. So back in the 60s, that's all they used to do, was just completely remove it.
Really?
Full meniscectomy. Yeah. So if there was any form of injury, tear, anything that they identified, they would just take the whole thing out. Thankfully, doesn't happen anymore. We've started to realize how important the structure is in terms of protecting the knee and increasing the longevity of the knee. But yeah, in that particular scenario, it's quite. I would say they're probably the grey area, trickier clientele, the ones who kind of sit just kind of on the cusp of degenerative. It may have been a traumatic injury that brought them into clinic. Though it's one of those where if they were to go down the surgical route, there's a higher risk of them having an arthroscopic partial meniscectomy, which unfortunately there's a number of studies that have come out that have shown that would increase the contact pressures up to 350% on the knee.
Wow.
So a significant amount of obviously this is dependent on the size, how much meniscus tissue they take away, but that is, it's a scary figure. And to be honest, I do tell patients this. I do kind of give this information to them because I think it's important for them to know potential consequences if the surgery doesn't go the way planned. So if they can't have it repaired and it turns out that they've had a meniscectomy, their knee's going to be in a much worse position in the long term. So I guess it then flips back to how much is this affecting your life? Is there alternatives that we could explore first before we go down the surgical route? Again, it's plug in rehab and physiotherapy to try to strengthen and stabilize that knee. Is there any brace options that can help to kind of reduce the rotational forces on the knee? I find the biggest thing of all though is activity modification.
Yeah.
And what is it that they do for a living? It might be that, as you've said, they play football and they just not as a full-time job, but they may do that as an amateur athlete, and their full-time job is as a plumber, so they're on the knees all the time. And unfortunately, we do find that cumulative load and that cumulative pressure going through the knee puts them at higher risk of getting kind of degenerative based tears. Like they're almost like micro tears that happen over time and eventually sort of join up into a bigger tear that becomes symptomatic. So if it's having that conversation with them as to, is there a possibility that we can work around this and try to manage this without going down the surgical route? And many of them are on board with it, and they're keen to kind of go down that route and have that opportunity to recover. And some of the evidence does suggest that there was a kind of a consensus meeting, a review that came out earlier this year, actually, that kind of had a lot of the surgical colleagues across the world meeting up and discussing the evidence as to how best to manage it. And as we're leaning more towards the degenerative ones, I know we've kind of not fully gone into that conversation yet, but those ones we want to give them an opportunity. So 3 to 6 month opportunity of rehab before then we consider, surgical intervention. That can be tricky though. And I've had a few that have bitten back, sadly, despite the best intentions.
This is what I consider the more challenging of the two type. I realize it's on a spectrum, but if we go from the acute kind of obvious locked cartilage tear, probably it's fairly obvious then you get to the more degenerative, and in my just from experience, and I might be wrong, but that conversation where you've got someone who had a scan or opinion that says you have a cartilage tear, but it's not the bucket handle big ones, it's a degenerative horizontal. And we know from the evidence that it's, especially if they're in the 40s, mid to late 40s, 50s plus, it's probably not the best idea to be going in there surgically because we can know the effect long term. And you say, well, how about rehab, physio, all that stuff? But that line of, but I've got a tear. And how do you try to manage that conversation? Because I imagine it from experience, it must be quite tricky.
It is tricky, and it all comes down to how that information from the MRI is being relayed back to the patient. So it's challenging for me, and sometimes frustrating for me if they've seen. Unfortunately, often seems to be the medics that tend to use the more medical-based jargon and say, talk about it as a tear or something, really significant in the knee, and they would come to me in clinic with that kind of notion that, well, it's torn and need surgery to repair it or get rid of it type thing. It's challenging in the sense that if I get that opportunity to relay the MRI information, then I feel like I have a bit more control over it. And even though there is a tear there, I tend to kind of reword how that MRI scan has been delivered. I quite like the word lesion a little bit better.
Okay.
It seems to be less harmful in how it's kind of picked up by patients in the terminology. And if I talk to patients as though you've got a meniscal lesion, but there are many people out there who have these meniscal lesions. There was a lovely study by Laura Hauger in 2017 that looked at, I think there was about 290 MRI scans in asymptomatic patients, and there was 30% of them, or I think 32% had a meniscal tear, but 97% of them had some form of abnormality in the knee. So by relaying that information back to them, I can almost normalize the fact that they've got this structural injury, particularly if the MRI is telling me this injury is in the white zone. It's a small injury. There's every chance that this is going to do well with rehab. Even if we re-MRI'd it in, let's say, 6 months' time, and the MRI again picked up the same lesion in there, but they're symptom-free. So we've avoided anything more severe. So we've avoided an arthroscopic partial meniscectomy that would put their knee at much worse position. So it's just trying to reword it. Obviously, you're not effectively bending the truth. You're not saying it word for word in terms of how it's being described on the scan. You're kind of normalizing it for the patient to understand and have the reality of, is this going to be better without an operation? And often they do.
Yeah. Mike, how do you try and help people understand their options with a degenerative tear? Especially if they're in the kind of late 40s, 50s category. We don't want to go in there necessarily and poking around too much.
Yeah, so as Carl's just alluded to, I think being careful with the terminology that you're choosing. So wear and tear, I'll use that as a term from time to time, or just damage rather than, as he's saying, that this tear in there. I think I'm usually very open and honest with them and say that historically we used to, lots of people would get surgery for these and bits of the meniscus would get chopped out, but explain to them that now we're seeing the consequences of that sometime later, that we see the rate of degeneration then in that compartment of the knee rapidly speeds up. And we see that with patients coming through clinic now, that the consequences of those early bits of meniscus being taken out when they were a lot younger, and I think patients are very appreciative that you just, as long as you're open and honest with them and explain your rationale for why you're suggesting that's the best course of management for them, you'll very quickly get them on board.
And again, a high level athlete, end of career, or even just weekend warrior, if they're talking about can I still do this with my degenerative tear? I'm not talking massive bucket handle and all that stuff, but I presume the option is yes.
Yeah, I think lots of the time, again, it's managing expectations. So it's yes, definitely. Our goal is always to get them back to what they were doing before. And I will always say that to them in clinic. I think I'm also conscious that I'm probably a little bit different to Carl in the sense that as a clinician, my time with that patient on their journey is a much smaller snapshot. Whereas from a physio perspective, you're often going to get multiple contacts and it's towards the latter stages. So I am always a little bit careful that I make sure whatever conversation I'm having with them is then not going to cause the physios any difficulty later on. And it's kind of setting a scene for them, building them up and doing some of the early expectation management. So then that when they do go through to be managed and progress through those conservative steps, they have some idea, but the physios are then in a position to bring that on and develop it and take it to the next step. And that's really important from my perspective, I think, because the more experienced I've got, you can certainly give people too much information. And even if you've got exactly the same type of tear, exactly the same imaging in front of you, the consultation that you have with that patient could be completely different just depending on who you've got in front of you at the time. So having that ability to adapt how you're relaying the information and adjusting it accordingly is really important.
Absolutely. The final thing I was going to ask with meniscal tears, is someone who's got, again, we'll put them in the 30s category, they can go either way, maybe not a major tear, but could, and they ask about what's the long-term consequences. If I was to get this operated on, hopefully it get repaired, what could be the downsides compared to leaving it? Especially from a kind of an if they ask, will this cause me more arthritis in the future? Where would you go with it?
Yeah, it's just as I've kind of alluded to already. Really, it's if they have a repair, then we're kind of preserving the original tissue, so they're going to have a much better outcome if that is successful. They are a little bit more challenging to manage with the repairs, particularly in the earlier phases when we are trying to kind of protect the repair. That they're usually non-weight bearing for the first sort of 6 weeks in a brace. Particularly the root and radial tears that I was mentioning before. The bucket handle longitudinal ones tend to be full weight bearing, but in that earlier phase, it's much more challenging to kind of get them through the process, really. But yeah, I mean, I think in terms of the prognosis, they tend to do well, the repairs, I would say, apart from the odd ones, which, as I said, even though that the evidence is saying a 20% failure rate, it's not actually what I'm seeing in clinic. Whereas the arthroscopic partial meniscectomies, they tend to do very well very quickly, and they tend to be in and out surgery. Their symptoms seem to be a lot better generally. Sometimes they can be sore for a couple of weeks, but then they tend to actually do okay in the short term. But in the longer term, the consequences are that there's a much higher risk of developing osteoarthritis in the knee. And again, it's, if I'd have seen them prior to the surgery, would be having that conversation about, there is a risk. There's obviously a risk of, in certain instances, of not doing any surgery, but there's a risk of having the surgery in terms of the amount of load and contact pressure that's going to go through the joint and ultimately increase the risk of arthritic change in the knee. So there's risk regardless of what route you go down. And I think it's just kind of, working through the nuance really with individual patients and their particular needs, their particular situation, and their wants and expectations need to be thrown into the mix as well, and trying to kind of manage the conversation around that. Interestingly, there was in terms of meniscectomy, there was a study called the Fidelity Study. I don't know if you're familiar with it.
When was it? Remind me.
It was a while ago now. I think it was early 2013, I think.
Yeah.
And this came out of Finland, and it looked at comparing an arthroscopic partial meniscectomy versus a sham meniscectomy, which inevitably was just going in, having a look around, coming back out and sewing them back up. And the results of that were that there was the arthroscopic partial meniscectomy was not superior to the sham, and this is with degenerative tears. And patients improved exactly the same over a 12-month period with both of those surgical options. Interestingly, the sham did better, as you would probably expect, really, in terms of radiological findings. You know, there was not the same amount of osteoarthritis when they were re-imaged over that 12-month period compared to the arthroscopic partial meniscectomy. So it kind of gives us a little bit of ammo to say, well, actually, unfortunately, we can't do sham procedures on people, sadly. It'd be great if we could. But it kind of gives us a little bit of ammo to say, well, actually, is it really doing anything to the knee? Is it just the placebo of the surgery? Unfortunately, it's tricky. But again, it just gives a bit more ammo to kind of think, well, can we be managing this in a different way? Can we be managing this more down a rehab route?
I think on that is often that's where that shared decision making becomes so important, because you will definitely get patients who will therefore opt for that conservative management, but with the appreciation and that, again, having that MDT approach and getting the good relationships with the physios from my perspective is really important, because then if they do start to get mechanical symptoms, or they're just not quite getting back to where either the patient wants to be or where kind of physio expects them to be in terms of their progress, then that's at that point, then we can get them back in and have those conversations. And again, I think explaining to the patients that whatever decision is made, then it's not one that's set in stone. There's other options that we can consider. So the process always evolves as they're moving through that journey.
Yeah, it's important you mention that, Mike, actually, because again, just delving back into the research for a second, there was a trial called the Meteor 1 trial that looked at, again, the difference between someone who'd had a degenerative meniscal tear, they'd had an arthroscopic partial meniscectomy plus standard physio or standard rehab versus just rehab. And 30% of those who were given the opportunity, or who were in the rehab only arm, they crossed back over to surgery. So that gives us an idea of how many of those degenerative patients would likely be successful. So we're looking at possibly 70% that would be successful with a 30% crossover rate, and that probably does fit, to be honest, with what I see. There are patients who are willing and very willing, and they will try, and unfortunately the trajectory of their progress just doesn't improve. And we then, either if we've not imaged them at that point, we would then maybe look at imaging them at that stage. I had one patient who comes to mind who that was the exact scenario. He was a 55-year-old runner. He did it for his mental health. It was a big deal to him that he was now not able to run. Pain on the medial side of his knee, no other medical history or anything. And he was very agreeable to trying the rehab first. And I've gone through all the kind of conversations we've just had now in terms of kind of discussing his options, and that's what he wanted to do, which was great. We tried it. I worked with him, so we worked through kind of periodized kind of strength conditioning, but we just could not really progress him. His pain was just too significant. When we then invited him back into clinic, we re-MRI, or we did an MRI, sorry, and the MRI showed he had a flipped fragment in the joint, which is interesting because he could fully extend his knee. It was just pain that was his main problem. So he ended up having a arthroscopic partial meniscectomy, and he's done really well, and he's managed to get back to running. So it's not always clear cut, but it kind of does fit in a little bit with where the evidence is taking us at the minute in terms of how to manage certain cases.
Speaking of evidence, what is I end all of these asking about the future. So you mentioned about the ACL bracing and the evening next month. People can hear about it. What about meniscal injuries, do we know if there is going to be any changes in the future to how we manage them and what we do about them?
It's always a good question. I don't find that meniscal injury is as researched. It's not as well researched. It's not got the same level of interest as like your ligamentous injuries of the knee, ACL in particular. I'm sure that there will be. There's certainly more evidence coming out around biologics, and Dr Michael probably be better at kind of explaining a bit more about that. And how that will help the meniscus. I guess that it would be then looking at other sort of randomized control trials. There is another Meteor study which is actually looking at the benefit of having an allograft. So it's again a cadaver based basically, and it's utilizing somebody else's meniscus in your knee if you have an injury. Again, it's very nuanced as to who would be the right candidate for that, but again, there's going to be evidence coming out around that shortly, which we'll look forward to.
What's your thoughts, Mike, about the future?
Yeah, I think as Carl said, it's definitely not got as much pizzazz, so lacking in terms of the research versus lots of the injectables are looking understandably at the degenerate end of the spectrum, not just for meniscus but knees, just because of the significant impact that has on a massive proportion of the population. But I think as meniscal injuries being a part of that, definitely the injectable therapies, the biologics, stem cells, all those sorts of things that ultimately all comes back to how we can do everything possible to manage it conservatively and just encourage it to heal, especially those tears we talked about in those outer 2/3 that will be a lot more amenable. Is there something we can do to try and get those to settle down in the absence of the mechanical symptoms that would need a surgeon early on?
I was actually going to ask, everyone has their, especially in sports teams, the ACL or the ligament injury prevention programs. Does that get applied to meniscal injuries as well? Or is it not as much of a thing that we can prevent these injuries, especially in athletes?
Yeah, I think as with most injuries, just having a well-rounded strength and conditioning program, understanding your players, where their strengths are, where their weaknesses are, making sure the players appreciate those, and the whole team's approach then is individualized towards doing as much as possible to minimize their risks, and knowing where their deficits are and keeping an eye on that progress. You can imagine there's a lot of data and work goes into just day to day, even look at how much loading they're having, when they might potentially be at risk on more days than others, trying to adapt what they do. I think specifically with the meniscus, it's just looking at their overall strength and any asymmetries and trying to address those. Certainly most of the significant meniscal injuries I've seen or have all just been unfortunate positions they've ended up in. I don't think there's anything you've specifically done to prevent those. Not in the same way that we look at the biomechanics, perhaps in relation to the ACL, certainly in some of the women's players at the moment.
Yeah. Right, so we've talked about this ACL evening coming up next month. Carl, tell us all about Simply MSK and what's on offer and what people can. I'll put a link in the description to this as well, but tell people what they can find and access.
Yeah, so Simply MSK is an education-based company that myself, Michael, and 3 other clinicians are involved in. And just to kind of give a little bit of context, which you might have we may have discussed before we actually went on air. We all kind of work together in Bradford in an acute MSK clinic, and within that clinic, we kind of found that a multidisciplinary approach yielded kind of better results for patients, and certainly better patient experience as they kind of went through the process. And we were kind of fortunate really to be able to be in clinic with, ourselves as physios, sports medicine physicians, and other medics. We had emergency nurse practitioners, we had the radiologists, radiographers, orthopedic surgeons, literally in the next door. So we were kind of treated to the fact that we were able to kind of work in this multidisciplinary approach. So what myself and Dr. Alistair Jones, who's one of the other directors, we were on a train journey, funnily enough, down south, and we just had this conversation where we were thinking, well, why is this MSK clinic the exception to the rule? We're kind of getting this additional training and support and understanding of the multidisciplinary team and how it can impact and how it can give different perspectives and different kind of thought processes in terms of how we can manage these conditions such as meniscal injuries with a higher quality, as opposed to kind of just thinking within our silos as physiotherapists being trained by physiotherapists or sports medicine physicians being trained by sports medicine physicians. Kind of looking at it as a full team picture. So that's where the kind of idea came from. So that's the context behind it. So in terms of what we've looked to do, we've started out doing lots of face-to-face talks, utilizing a multidisciplinary approach. And we've had loads of positive feedback from the people who've attended our talks. They've really enjoyed the kind of different angle and different direction that we've gone compared to kind of your normal kind of training packages. And what we're looking to do over the next year or so is kind of build more of an online platform. It's not necessarily something we've pushed so far. We've been more face-to-face. But over the next year or so, we will be building an online platform where there'll be access to lots of different courses for lots of different MSK conditions. And hopefully we will be able to get lots of different disciplines on board to kind of provide this multidisciplinary approach from the moment of injury to that moment where they return back to sport and all that happens in between. So I think it just gives a more rounded training experience, and that's what we're hoping to give. So yeah, that's it.
People can I put a link, but people can find it online on yourselves. Both, I know Carl's on LinkedIn and Instagram. Michael, you're on LinkedIn. I found you there. Are you anywhere else?
Yeah, I am also on Instagram. Probably not quite as present as Carl, but I am on there as well. But yeah, you can find all the links on my LinkedIn page. Yeah.
Mike, was there anything about meniscal injuries that you wanted to say that I've missed?
No, I don't think so. No, I think we've had a good chat through most of the pathology related aspects.
Carl, anything you want to say that I've missed?
I probably would just like to just put one more patient case study just forward, just because I think it's important just to mention, as it kind of took me by surprise a little bit. And it's not it's not a pleasant one to end on, but it's an important one. I had a young lad who, early 20s, he was at university playing football. Normal kind of mechanism of injury, really. He kind of planted his foot, pivoted, felt a pain on the medial side of the knee, went to A&E, and he wasn't particularly managed very well. Unfortunately, in A&E, he was kind of been described as a trauma to the knee, and then he was sent on his way, but there was no X-ray, no imaging or anything. Anyway, he was meant to be referred into our clinic, and eventually chased that up, and he landed with me maybe 6 weeks down the line. So at the time, he was still getting this pain on the medial side of his knee, and obviously my differentials then are, is this an MCL injury or a meniscus injury or possibly an underlying ACL injury in the background? He wasn't really complaining of any instability, and he could fully straighten and bend his knee. He was just in pain on the medial side. So when I was testing him, he was actually more sore around the kind of proximal end of his VMO, essentially, vastus medialis, as well as on the joint line. So it was one of those where, a young lad, traumatic injury. I'm thinking, well, we probably do need to image this to try and figure out what's going on. It's more than likely a low-grade meniscus injury. All the ligaments tested normally when I tested it. So I organised an X-ray, and the X-ray came back as an osteosarcoma. Oh. And it was quite a nasty, aggressive one as well. So I think it's just worth mentioning, just to put on people's radars, that sometimes it's not always as it seems. That to me was a normal mechanism of injury, a bog standard this could be a meniscus tear. Let's image it, work it up. We usually X-ray before we then work up to an MRI, just to rule out things like that. And unfortunately, that's what it picked up. And then we've had to kind of escalate that to the sarcoma teams, which is sad for the young man. But as I say, it's worth mentioning because there is importance in imaging at the right time, and not everything's as obvious as it seems.
Out of interest, who tells him?
So that was one of the orthopedic surgeons then who would have that conversation. I think I'd be happy to have the conversation, even though it would be a very difficult conversation. But as not being a medic myself, I feel like that goes beyond our scope, and I think that then needs to be escalated to the right people who know a bit more, really, frankly, in terms of how to manage these sarcomas.
Lots of because you'd be saying lots of I don't knows.
Yeah.
Yes, exactly.
Lots of unanswered questions. Mike, do you have any particularly? I normally ask people what's been the hardest conversation, but you may not have known it was coming. And Carl's given a great example there. Do you have any particular ones that stand out as he was talking about, particularly difficult ones? It can be meniscal related or not.
I think for me, often the hardest consultations are where your patients come with a perceived idea already, or they're quite set in stone before you've had any chance of getting to them. I think the ones who've gone to the nth degree and have loads of information are actually okay, because by the time you've chatted to them, and you can quite comfortably get them around to your way of thinking, because they've got that level of detail of understanding. But the ones in between somewhere, they're often the trickiest ones that take some time to get them around to why you're thinking what you're thinking, and why what you're suggesting or proposing might be different to what their expectations were. I think they're often the hardest ones to manage, and that would probably come back to what I said before, where I'm quite conscious then of making sure that their next step in the journey, whether that's going to see a surgeon or it's going on to physio, that you're setting up colleagues and other healthcare professionals that are going to be involved in that journey in the best way as well, because you have to manage that moving forwards. You don't just want to pass that on to the next person in the journey, if you like.
Yeah. I work in obviously an MDT is blessed as well with in a pain service, and we find that if the message, even if it's not always what they want to hear, but if the message is repeated from the same people, it's more likely taken and it's easier to move forward. As you say, when there's conflicting views and opinions and different methods, and especially as you said, the people who are slightly informed but not completely, will have all the information, all the facts to hand. They might start cherry picking or just going on the thing that appeals to them, so to speak.
Yeah.
Grand. Well, I'll say we talked about the conversations, but if people want to know more about actually assessing or treating these injuries, then they can go on your website, or there'll be stuff on there at some point, I presume.
At some point there will be, yeah.
Yeah, definitely. And by all means, we have the clinic set up. We've had people come from Scotland and all over the country. So if people want to come and reach out to us and come see what we do in the MSK service at Bradford, they're more than welcome.
So, Mike, was there anything else you want to plug apart from the course?
No,
and the
don't think so. No. I've done a good job already. Thank you.
Well, thank you both for coming and being my first dual interview. There's always normally one part, but two is, and it's actually been very interesting hearing the different views. And like I say, if people want to know more about the website or the talk next month, they can find it in the description.